good to be here this afternoon. I've actually never been in the Manlius Library, even though I live 3 blocks from here. So it's, I know. So I'll come back. I'll come back. But it's good to see you all. It's particularly good to see my very good friend, Marianne Corsiniti, who I've worked with, I won't say how long.
Raise your hand.
So I was asked to talk about the U.S. healthcare system, which always seems easy when someone asks me, can you talk about the U.S. healthcare system? Sure, because I talk about it all the time. Then the challenge becomes, how do you condense the conversation into any sort of manageable bucket for any length of time? And I'm told we have no more than 2 hours, and I certainly will not lecture you for 2 hours by any stretch. But I want to give you some background material, kind of wander through that. But we can go in any direction that you'd like. So if you have any questions as I go along, just stop me and we'll go down that path. When I finish the formal part of the presentation, if there's are there any questions that you'd like to entertain, or any issues you want to try to unpeel, I'll be happy to try to do that as well. The U.S. healthcare system is really a very complicated animal, as some of you I'm sure have discovered from having entered the U.S. healthcare system in one form or another. I was the CEO of a hospital years ago. I'm licensed as a nursing home administrator. I've worked in long-term care, I've worked in acute care. I chair the board of the Visiting Nurse Association of Central New York. I'm on the board of St. Joseph's Hospital. I'm on the board of St. Elizabeth's Hospital in Utica. I'm on the board of a hospital in Hawaii. So I have been involved, I remain very actively involved in the delivery system itself, which you don't really realize how complicated it is and difficult it is until you actually have to grab a hold of it and deal with it. And I just had I'm still living in a situation where I'm dealing with the healthcare system on behalf of a relative. My mother's sister, who's 95, fell last week, getting into bed, broke her hip, laid on the floor all night. My mother found her the next morning, fractured hip, 5 fractured ribs, a big cut into the hospital, surgery, into a nursing home for rehab. Just the conversations that I had with the discharge planners and the care coordinators and the social workers reminded me again how absolutely Byzantine the system is and how complicated it is for people to navigate. And I know the questions and I know the answers, but it was extremely difficult and very frustrating. So it's a good reminder that even though we think the system, and we keep calling it a healthcare system, it's not a healthcare system. It's an accumulation of businesses and organizations and services that has evolved over the last 100 years. I teach a course every fall in the evolution of the U.S. healthcare system and trail it from 1900 to about now, and really look at how hospitals evolved, how physician practice evolved, how insurance evolved, and how the mental health system evolved. And every one of those threads evolved very differently and evolved according to political pressures and economic issues and human concerns, but more so economic issues. I think one of the commonalities about the U.S. healthcare system is that form follows financing. How we pay for the system is how the system evolved. So we've ended up with this thing that is 1/5 of the economy. 1/5 of the economy. Healthcare is the largest employer sector in Onondaga County. And it's unrelated pieces and parts that keep kind of stumbling along. So we'll kind of get into some of that. We'll talk about some background. We'll talk about healthcare reform, otherwise known as Obamacare, which I've come to like the label. I didn't like it in the beginning. And we can debate whether you think the current iteration of healthcare reform is good, bad, or indifferent. And I'll show you what some of the consumer polls talk about. So let's just get into it, and then ask me questions, stop me, and we'll have a conversation more than a straight lecture. So one of the realities of the U.S. healthcare system is that the costs have increased substantially over the last several decades. This slide shows us the trajectory of expense, total national health expenditures in constant $2012 from 1970 to 2013, and that trajectory has just continued to go year upon year upon year. It's flattened a little bit in the last couple years, 2 years or so, but we've had a consistent increased trend in healthcare spending. On a per capita basis, healthcare spending has also grown significantly from about $356, or in 2013 $1,700 per capita, to $9,255. So it's nearly $10,000 per capita spending in the US healthcare system, which is a substantial amount of money any way you slice it. We'll look at this in an international context in a couple moments. Healthcare spending growth has outpaced growth of the US economy. So even when the economy has grown, healthcare spending has grown even more. And we've kind of come to accept it. We used to talk about reducing spending in healthcare, and now we talk about reducing the rate of increase in spending in healthcare. So I guess it makes you feel a little better that maybe that's achievable and reducing actual spending is not achievable. But we're up to 17% of gross domestic product, and again, that's almost 1/5 of every dollar is spent on healthcare in the United States. And in some Rust Belt kind of parts of the country like we live in, it's even more when you think about employment and you think about the contribution to the community. If you look at small communities, the hospital and the school district are usually the two largest employers if the hospital remains, and we're seeing so many hospitals in rural parts of the United States close down and consolidate, which is not necessarily a bad thing, but it is an economic hit to those communities that lose their hospitals in a significant way. Prices have historically driven healthcare spending growth. So the price of a unit of healthcare has gone up consistently over the years. And this graph just shows you what contributions consumption has made to healthcare spending, and the orange line is the price that relates to increase in spending. So the price has actually come down. The price per unit of healthcare has actually come down in the past couple of years, and utilization and price now are about 50-50 in terms of what drives the increase in spending.
Explain the unit.
The actual fundamental cost, so that the price of healthcare, price of drugs, price of medical supplies, cost of hospital care.
Visit.
Yeah, a visit. Just the absolute cost used to go up every year. And drug costs had a lot to do with these really significant increases in spending in those past years. We've not had the same kind of increases year upon year of pharmaceutical expense. Not when you go fill a prescription, you wouldn't believe that, but the price of drugs has not increased as much in the past couple of years, largely because some of the more expensive drugs have come off patent, and they're not as costly as they used to be. So it's a mix of utilization and price. This is an important piece of information to remember when you think about healthcare spending, in that we spend about, this blue line is private spending. This is out-of-pocket spending. It's employer-based insurance, which is the largest amount of money that goes into the healthcare system. It's private dollars. The orange line are public dollars. So we have a mix of about 50-50 public and private spending in the United States, which is very, very different from most other countries. And it's important to remember that how much of a contribution we make on the private side versus the public side when you think about what to do next with the healthcare delivery system. So healthcare spending increases have actually slowed down from the 70s. That was the time period when healthcare spending was at its highest rate, and it's come down pretty consistently over the decades. The blue line is healthcare spending, the lighter line is gross domestic product. But you can see up until we hit the recession, the latest recession anyway, GDP grew more slowly than healthcare spending, where healthcare spending grew more quickly than gross domestic product. But we've seen a slowdown just in the last couple of years. We honestly don't, the economists don't really understand why the healthcare spending has come down since 2012 related to the GDP. Some economists think it's this general slowdown in the economy, and people tend to purchase less healthcare when the economy is less strong because of the out-of-pocket component of cost. Some economists believe that it's a concerted effort on the part of parts of the delivery system, particularly the pharmaceutical houses and the durable medical equipment houses and medical device manufacturers, to slow the price growth down for fear that they will be really the target of Washington and the state's efforts if they don't slow the price down. And I don't disbelieve that. The healthcare delivery system, the business side of it, is pretty slippery and reacts quite well to economic pressures. And I think we've seen this before. I have a chart somewhere that looks at some of the governmental efforts to reduce healthcare spending, and you can see the government launches an effort, the industry responds, the government lightens up, costs go back up, the government launches an effort, the industry responds, the prices go back up. So whether Obamacare or healthcare reform in 2010 threw enough of a scare into the delivery system for it to last or not is yet to be seen. And it's yet to be seen exactly what will happen with the Affordable Care Act's long-term implications on healthcare spending. We'll talk a bit about the Affordable Care Act in a moment. So this gives you a context with numbers that I'm sure you can't read from where you're sitting, but this is comparative health spending in 2011. So when I say comparative health spending, this is spending in the United States. And these dollars have been adjusted for purchasing power, so they're equivalent across countries. And these are the countries that we typically benchmark ourselves against, as well as some developing countries down at this end of the graph: India, China, Turkey, South Africa, Mexico. But these are Norway, Switzerland, the Netherlands, Austria, Canada, Germany, Denmark, Luxembourg, countries that are economically developed and similar to the United States. This orange bar is the average of the OECD countries, the average of the developed countries. So it's Europe, Australia, Japan, New Zealand. So when we look at our spending in 2011 in US dollars, purchasing parity adjusted, we're spending $8,508. The OECD countries are spending on average $3,322. That's a big difference. Marianne.
Are there outcomes?
Just wait. That's coming. That's the next question. Of course, oh, okay, fine, we're spending that much money, but are we getting value for it? If we're getting value for it, I'm all for spending the money. But that's something that I'll let you judge in a moment when I give you some more data. The other interesting piece is the darker bar is public spending, the lighter bar is private spending. So look across these countries. We're very unlike the rest of the countries. When we look at the OECD countries, this is public spending, this is private spending. So we spend not only a huge amount more, we spend a lot more private dollars per capita than any other country. This bar would also shift up here. Actually, it would shift a bit if we took into account the reality that employer-based health insurance is exempt from income tax. And 65% of the people in the country get their insurance from employment-based health insurance. So when you get your employer pays your health insurance bill, you see it on your paycheck as a deduction, and they pay a portion. But that portion that the employer pays, and it's typically 80% is for large companies, that 80% is not taxed. So if we took the money and gave it to people as income and said, you go buy your own health insurance, there would be an enormous tax boom to the federal government. And every so often, the feds try to do something like that, and that's not popular at all among many people, so they have backed off on that. So this gives us a context internationally. We spend just one hell of a lot more money than any other country, any way you slice it. So one argument is, well, we're sicker. We need to spend that money because we have more disease than these other countries. Not true. So here's expenditures by disease condition, heart-related conditions, trauma, cancer, mental disorders. Here's relative prevalence of disease, United States compared to OECD countries. And again, this is France, Germany, Italy, Spain, United Kingdom. So we're comparing against countries that are quite similar to ours. The only places where we have somewhat higher, a little bit higher, is trauma-related disorders, cancer, and diabetes. Now, why do we have higher rates of diabetes? Obesity, right. Because we have the highest rate of obesity in the country. We host at Maxwell groups of international students, and we host a lot of people from mainland China. And we've actually built a module into the orientation. Now, don't stare at people who are heavier, because they would come here and think, look at these people, because they're not accustomed to seeing as many well-nourished people as we are accustomed to seeing. So other than diabetes, which is not largely a lifestyle, there are lots of different reasons why people develop diabetes, but it is associated with obesity. So other than that, we have lower rates of COPD and asthma, lower rates of hypertension, osteoarthritis, back problems, and other kinds of things, which have lower rates of heart conditions. So are we sicker? So therefore, that's why we're spending more money. The answer is no. We are not, on average, sicker. We're on average healthier for many things. So it's not the fact that we have higher rates of morbidity. Now, if you pull out one particular country or another, things get squirrely. So if you take Norway and you pull it out, everyone in Norway is 6 feet tall and they're blonde. So they're it's a more homogeneous population. So it's kind of hard to compare sometimes. Another just caveat in any of the stuff that I'm giving you with respect to international comparisons is these are averages, because that's the only thing that you can really work well with. We have high rates of disparity. We have subsets of the population at one end who are much, much healthier, and subsets of the population at the other end who have much greater burden of disease. And the greater burden of disease is driven very, very much by socioeconomic condition. We used to do work looking at healthcare disparities and say, oh, it's African Americans, it's Hispanics, it's this, it's that. When you control for everything else, fundamentally, bottom line, it's socioeconomic status. It's income and education. What's education first, which drives income, and it's environment. So when you look, for example, at health statistics here in Onondaga County, and you compare it to the rest of the state, of course you exclude New York City, of course, because New York City is always an outlier, and you say, well, do we have higher rates? What's our infant mortality rate here in Onondaga County compared to the rest of New York State? No, Onondaga County's not bad. We're pretty consistent. So what if you take out the city of Syracuse and you look at the rest of Onondaga County excluding city of Syracuse? We're better. Why are we better? Because you look at the socioeconomic status of the people who live in Onondaga County outside the city of Syracuse. Pretty good. You take the city of Syracuse and you compare that against the rest of New York State. Not a good picture. High rates of infant mortality. Then you take out a couple of census tracts, the near west side, the south side, and you look at rates of infant mortality there compared to any measure, and you find enormous disparity and very high rates of infant mortality. And those are directly correlated with socioeconomic status, access to information, really, access to nutrition, access to a variety of things, not just medical care. So averages can mislead you, but on average, in the United States, we spend a whole lot more money on healthcare and we're healthier, yes.
Trauma related, is that due to military activity?
No, it's accidents, but it's also violence. We have much higher rates of violence outside of countries that are in war. Higher rates of violence than France, England, Great Britain. We have much more use of guns, more gunshot wounds, more violence in the streets. If you look at some of the neighborhoods in the downtown part of Syracuse, there's a murder, every week. I do a lot of work on the near west side. We're putting together a project linking No James grocery store, which, by the way, it just went through a renovation and is absolutely wonderful. And they have their own butchers, and they actually do cut meat. Wegmans pretends to. They have people walking behind them but they really don't. If you go to No James, you can have meat cut the way you want it, and the quality is really very good. So No James is across the parking lot from St. Joseph's Hospital's Primary Care Center West, and we're working on a project to actually link medical care with nutrition, with what you buy in the store, what food you have access to. And not just geographic access, but access in terms of what is that vegetable? How do I cook it? What's its nutritional value? And we're putting in a program where we are funding prescriptions that physicians in the primary care center can write a prescription for fresh fruits and vegetables, and the patient can go back across the parking lot and fill a prescription for fresh fruits and vegetables with information about how to use them. So I'm a director of the Lerner Center for Public Health Promotion, which is a public health center at the Maxwell School, and our focus is on improving the health of the population. Forget the healthcare delivery system. What do you need to do to improve overall health, but that's a kind of.
Can I just ask one quick?
Yeah.
If you write a prescription for, say, fresh fruit or vegetables, is that, does that have to get paid for out of a typical family's SNAP budget? Or
No.
Or that's outside of that?
We pay for it, the Learner Center.
Because part of the problem is the benefits, the SNAP benefits, food stamps.
Right.
Are arguably at a level that doesn't necessarily enable people to buy expensive fruits and vegetables.
No, this program
And
is.
that's not the only.
This is privately funded.
Okay.
So the Learner Center is a privately endowed center, and we're using foundation funds to do that. The interesting thing about EBT purchases versus cash or credit purchases, when you look at profile purchases in a store like No James, it's very cyclical. So that you get your card benefits on the first of the month, and you go in and you see EBT purchases really high for the first week, and then of course it trails off because they run out of money on the card, and then credit card purchases go up. So how many of you actually could plan 30 days in advance what you're going to buy at the grocery store and what you're going to eat?
2 days.
Right, 2 days. I shop like I don't own a refrigerator. You know, I go to the grocery store virtually every day, look around and decide what I want to buy. But I have money every day of the month. I'm fortunate. I don't have to rely on just resources in the beginning of the month. So we're relatively healthier than the rest of than the comparable countries. Mortality rates have fallen steadily in the US and OECD countries over the last couple of years. That's the good news. However, this is the United States overall mortality rate, and this is our comparable countries. We spend a lot less, we spend a lot more, we're healthier, we die sooner. So,
That's not good.
no, something's wrong. So this is an interesting way to think about it. And actually, if you plot GDP per capita, gross domestic product per capita, against spending on a per capita basis, healthcare spending on a per capita basis, there is a direct linear relationship. The richer a country is, the more it spends on health. That's fine, right? That's reasonable. The richer you are, the more you spend on health. The only country that is a complete outlier is Luxembourg. I don't know why. There's only like 100 people in Luxembourg and they're all millionaires, but so that relationship falls apart. I did this analysis for provinces in China. The same relationship holds true. The wealthier a community is, the more it spends on health. Now, this particular plot has an R-squared of 0.88. Does anybody remember regression analysis? I tried to forget it. So regression is an economist tool that basically predicts the future based on the past. It's a measure of goodness of fit of a line. So it's the measure of how well the relationship between per capita spending in healthcare and GDP fits. So how predictive GDP is for healthcare spending. It's a 0.88. 1.0 is a perfect fit. If you work with graduate students, I do all the time, and they get a regression formula that gets 0.5, they are dancing in the streets. It's absolutely wonderful. 0.5 is like, wow. 0.88, I don't know what they would do. You know, economists don't tend to get that emotional, but they would with a 0.88 regression. So this is an extremely, extremely tight relationship, except for who? The United States. We spend 40% more than would be predicted based on GDP. So we've actually come up with an acronym for it, because that's what we do in healthcare when we don't understand something. We come up with a label that kind of sounds like add itis to it or something, and it doesn't mean anything, but it sounds like a disease, or it sounds like something that should be scientifically defined. So it's excess spending associated with wealth, ESAW, ESAW. So we know, we have this concept, we know there's excess spending associated with wealth. Why? And that's the major question that we keep circling in a lot of research. Why do we spend that much more than would be predicted based on wealth, when that relationship fits so very tightly and so very closely in every other country in the world, including developed countries. So it isn't just limited to developing countries at all. So we spend a lot more in every single area than of these other countries. So this is the US. We spend more on hospitals and nursing homes by a little bit, a lot more on ambulatory health care. Physicians, we spend a lot more on physician care than any other country. We also pay physicians a lot more in this country than any other country. Specialists earn 2.5 times more on average than in the OECD countries. Primary care doctors earn about 1.7 times more, twice as much as in other developed countries. And we have a much higher ratio of specialists to primary care in the United States compared to every other country. I have to be careful how I talk about this because my wife is a physician and she gets mad at me when I suggest that physicians are just greedy, avaricious businessmen, you know, angels of mercy. Pharmaceuticals and other medical goods, 155% more. So the other countries are spending a whole lot less in pharmaceuticals and medical goods. I was at the World Health Organization a few years ago, and I asked the guy who was the deputy minister for pharmaceuticals, I forgot his title exactly. I said, you know, what would happen if the United States negotiated for drug prices like every other country? Every other country negotiates for drug prices. Now, you'll be interested to know that the Medicare Modernization Act of 2002, which I always think of as the Medicare Middleman Multiplication Act, is what brought you Medicare Part D. How many of you have gone on the website for Medicare Part D? Isn't it fun, right? So that act has a provision in it that says that prohibits the federal government from using its bulk purchasing power through Medicare Part D to negotiate drug prices with the pharmaceutical houses. So it's against the law for the government to use its purchasing power. I don't know who came up with that idea. So I asked him, what would happen if the United States used its purchasing clout like every other country? And he looked at me and said, oh, just suck it up. And I was like, whoa, well, can you explain? And he said, well, you're the richest country in the world. You should be paying the profits for the drug companies so they can make drugs more affordable and available in other third world countries. Yeah. You can argue that, you know, it's a thought. Yeah.
What about the idea that the drug companies are doing all this research? The drug companies and
They are doing all this research, there's no question about it. But most of the expensive R&D is coming from NIH funding to begin with, coming from public dollars. Yes, they have R&D investments. It pays off very handsomely. It's really the profits. And the argument that, oh, if you reduce our revenue, it will reduce our R&D budget. That assumes that your profit margin stays the same. And your profit margins are among the highest of any industry group in the country. So, you know, it's interesting, there were some articles in the paper and in the lay press a couple of years ago about oncologists saying when Medicare stepped in and said, no, you can no longer quadruple the price of a drug given as a shot in the office and make pocket the difference. The oncologist said, we're going to lose money. I don't get it. You know, you're in private practice, your income is what your revenue less expenses. So now we're going to take away this boondoggle that Medicare allowed you to have. And yes, your revenue is going to come down, and therefore your income, which is $400,000 a year, is also going to come down. You're not losing money. So you all took math, you know, when you solved for where's the variable? Is the income what you're solving for, or is there something else in between that you're messing around with? So we spend a lot more in everything. I don't like this combination of public health and administration. We don't spend enough money on public health. What percentage do you think we spend of our large healthcare budget on public health, things to improve the health of the community, as opposed to treat disease? Any guess?
1%.
1%. Not that bad.
15%.
7%.
In between.
Yeah. So 93% goes for what I could call damage control. It's fixing things that, some of which, I mean, we age, things happen, fall down, things happen. But some of this stuff could be averted and minimized if we had some prevention. So we spend more money than anybody else. We spend a whole lot more on administration of the benefit than anybody else. We've got more people, you know, processing papers and doing administrative kinds of things than any other country. It costs 2.5 times more to administer a private health insurance benefit than it does the Medicare benefit. just for scale. Because the Medicare benefit's national, it's consistent. It is subcontracted to insurance companies. It's not administered directly by the government, but it's subcontracted with a lot of parameters around what it can cost. And the insurance companies are fine with that as a product line, and they make money on it. And it's still 2.5 times more expensive to process it through the traditional insurance mechanisms with all the underwriting and the advertising and everything else that goes along with private health insurance. I always have the president of Blue Cross come talk to my class every year, and I give the class lots of ammunition. So by the time he comes in, he's a friend of mine, and he's my neighbor, so sometimes it gets a little uncomfortable. But it's interesting to hear the students challenge him on the costs of health insurance. And our Blue Cross plan is a very credible plan, and they don't engage and never have in a lot of the more nefarious stuff that other insurance companies have engaged in. Here's the direct answer, Marianne. International comparisons, where do we stand with respect to Australia, Canada, France, Germany, Netherlands, New Zealand, Norway, Sweden, etc., Switzerland? So our overall ranking is 11 out of 11. We're the worst. So where we get good marks is effective care. This is access to technology. We have really good technology. I would be the last one to debate that. We are a very high-tech, low-touch healthcare system. So when you go in to see your doctor, they're happy to do an EKG. They're happy to order a test. And they're used to, you take all your clothes off, you sit on that sticky paper, and the nurse and the doctor come in with plastic gloves and they do things to you, as opposed to talk to you about what's going on. Most of the time, I shouldn't pick on doctors that much, but some of them deserve it. So we have good technology, but where we really fall down in terms of these rankings, and this is the World Health Organization ranking, so you can debate it, whether these are the right parameters or not. So it's a scale. Is in terms of efficiency, equity, and healthy lives. So we spend so much money, we have such high levels of disparity, and we don't get the outcomes in terms of length of life and reduction in morbidity. We have really good high technology carriers, that's absolutely correct, but we don't do well on the measures of efficiency, equity, distribution, and cost. So are we getting our money's worth? You can judge for yourself. These are the data that kind of speak for themselves. So that's the background. That's the depressing part of the U.S. healthcare system.
Why was England so much better?
Well, England had the Brits during World War II, while they were being bombed and they were in a mess. The British government said, well, when we win the war, we'll have all this stuff to clean up. Because the British, they never occurred to them they would not win the war. So they commissioned a report called the Beveridge Report. Lord Beveridge was the chair of it. And it studied what will have to happen post-war in Germany, in Great Britain. And it came out with recommendations around 3 areas: housing, education, and healthcare. And basically the premise of the report was you can't have good health and good healthy society without appropriate housing, and a lot of their housing stock had been bombed. Good education, their educational system was in disarray, and good healthcare, the healthcare system was in disarray. So that created the council housing system in Britain, the education system, and the healthcare system. And Britain, in the aftermath of World War II, took all the healthcare, all the hospitals, made them all public, brought it all together under the National Health Service. All specialists are employed by the National Health Service, work in a hospital. They're called Mr., and primary care doctors are called doctor. They earn a little bit more money, 30% more, give or take, than primary care doctors, but there's much more parity in terms of the way the physicians are treated. Everyone is covered. It's universal coverage, universal access. And there are some more delays than we have in this country. Not terrible delays. There are some. A friend of mine was a partner at PricewaterhouseCoopers when I was there, who was stationed in at the London office, and she married a British guy. And she needed to have a procedure done, so she went to the doctor, and they decided she had this procedure done. They said, well, it's going to be 3 weeks, and we'll call you, when the day is scheduled. We don't know yet, we'll let you know a couple days ahead. She's like, I'm a partner at PricewaterhouseCoopers. busy, I can't bother with this. So she went to a private clinic, because in Great Britain there is a small layer of private services that you would go to for simple stuff. You would never go there for high-tech stuff, because they don't make the investment in the expensive high-tech stuff. It's not profitable. So she had her procedure done. She was happy. She came home. Her husband was livid because she jumped the queue. The British are fine with that. They're very happy with that. So it's totally public. It's universal. It's controlled by the government. Salaries are lower for physicians. The input costs are lower. They can negotiate drug prices. They can negotiate everything. And part of it is the constriction of supply. The Canadians do the same thing. The Canadian system has been managed from an economic perspective partly by reducing capacity, and therefore you have waiting lines longer than we do in the US.
We were on the British system. My husband was over there for 4 years. They assign you to a doctor, for one thing. 2 women that we know of went blind waiting for their turn at the cataract surgery. And here it's like 5 minutes, and 2 weeks later you go 5 minutes on the other eye. The other thing is, if you go to the dentist, you don't get Novocaine unless you pay extra.
Yeah, dental care is a different issue.
So it's really not what we have here by most.
No, it is not the same system. It's not the same
But
culture.
to wait for cataract surgery, I mean, here it's so routine. And they went blind waiting for their turn. I mean,
They've acknowledged over the years that they've had issues, particularly around wait times and the like. No system is perfect. But the fundamental question you need to come back to is, what can we afford? What is reasonable? You know, the British also have something called QALYs, that are quality adjusted life years, that are used as a measure to decide whether a new technology gets picked up by the National Health Service or not, which is it's essentially clinical effectiveness review. If it doesn't work, they don't pay for it. In the United States, if it doesn't kill you, we're happy to pay for it, whether it adds any value or not.
If somebody in Great Britain decides to go outside the government, do they have to pay for the whole thing
Yes.
themselves?
Yes.
And do their doctors charge the same thing as our doctors?
No. I mean, they're proprietary systems. They charge more than they would charge in the National Health Service, not at the same rates that we do. Yes.
All I've heard over the last few years is that the Canadian system and the French system, if we had that, we'd be doing so well. And here I see that's number 9 and 10. What are we missing? What are we not being told?
Well, the Canadians, access to technology is less than we have here. But every system is very different. Now, there's a whole background set of data that you need to ultimately understand. How much of it is privately funded? How much of it is privately provided? Publicly funded, publicly provided? What's the level of benefit? What is excluded? What isn't? There is no perfect system, but some amalgam of lessons from other countries certainly can be used. Because if you keep fundamentally coming back to the fact that we're healthier, we don't live as long, we spend 2 or 3 times more than anybody else. There's something wrong with the system. Yeah.
Tom, you may get to this, but my question relates to what do you think would actually have to happen in terms of medical system crises that would enable the political system to respond to such crises in a way that would overcome the powerful lobbies that exist for the pharmaceutical industry, for all of the various components of the system who are fighting to, or for the most part, to defend their turf and and have an incentive most of the time to keep the status quo in place. That's part of the problem, because you know how Washington works or doesn't work. This is just one part of the Washington calamitous mess.
Let me go a few slides forward and I'll show you some of the political problems that we have with this. It is a political problem. But remember, it's 1/5 of the economy.
Right.
So that's a very substantial thing to try to attack. So healthcare reform. We have had a number of efforts to try to deal with the healthcare system. There was a report done in 1929 by the Committee on the Cost of Medical Care. And that report basically came to the same conclusions that a report that would be done this year would come to. I've always wanted to have somebody type it into Word and then just word search it and change the dates and reissue it and see. And people would say, yes, that's exactly the problem. Some of the same recommendations that came out of that report were the same recommendations that are the underpinnings for some of the more recent healthcare reform initiatives. But we've seen every couple of years there's some effort to try to reform the healthcare system. Now, even using the word reform, the choice of that word suggests that it's broken and needs to be fixed, not just tinkered with. So Roosevelt tried it through this part of the New Deal. He didn't get very far. Truman tried it as part of the Fair Deal, didn't get very far. Johnson probably made the most progress of anybody with Medicare and Medicaid. Nobody thought they would be as big as they are. Nobody thought that it would grow as much as they have, particularly Medicaid. Medicaid was kind of a throwaway sidebar when Johnson thought about it. There was national health insurance proposals during the Nixon administration. It was Nixon versus Teddy Kennedy at the time. And actually later, Teddy Kennedy said he really should have taken one of the proposals that Nixon offered because it was very similar to what the Clintons tried to propose in some respects years later, but he wanted something more pure. Nixon introduced the notion of market forces through managed care, so it was really managed care that started during the Nixon administration. And managed care was started by the term managed care or health maintenance organizations that are started by a physiatrist. Anybody know what a physiatrist is?
That's a podiatrist.
Oh, they don't like to be called physical therapists. They are specialists in physical medicine and rehabilitation, thank you. But they're physical therapists, right, at a higher level. So what's the goal of a physiatrist? Get you back to absolutely restore function. So this guy, his name was Paul Elwood, he lived in Minnesota, and he was an advisor to Nixon. He said, there's something fundamentally wrong with this. I'm a physiatrist. My goal should be to get people back totally functional, but I get paid if I keep them coming back. So if I keep them a little bit suboptimal, I can keep them coming back forever, and I can make all this money. So if I do what my discipline tells me I should be doing, I should just not do it. I should be, keep them kind of partially cured or partially healed.
Isn't that similar to the drug companies, that if they give you a cure for a disease, they lose all the money that they're spending for the treatment?
It'd be true of any intervention. If you could figure, if there's a cure, if you don't use it, and you're treating, then obviously there's that. And there is that kind of odd economic relationship that you have with your physician and with the whole healthcare system. That there's a lot of tension there, especially if you assume that your physician is acting as your fiduciary, is acting in your best interest. Can you count on a large industry segment that produces pharmaceuticals for profit to act as your agent and your fiduciary? So you need, the healthcare system is fraught with values and those kinds of judgments. So Elwood said, we need to create a financing system that encourages people to keep people well as opposed to just treating up to a certain point. And that was the notion of the health maintenance organizations, which morphed and got completely kind of perverted into what we now call managed care, which really doesn't have the same kind of objectives as health maintenance organizations. Carter tried it. Carter was a nice man, but it didn't go very far. The Clintons tried healthcare reform. That didn't go very far, either, for a variety of reasons. We may have Hillary and Bill back in the White House, so we'll see what happens with that. So Obama was successful in the Patient Protection and Affordable Care Act, and I think in historical hindsight, it will be viewed as a major step in productive change in the healthcare system. It has been problematic. I'll be the first one to admit that. So why has healthcare reform been so hard to achieve? It's largely ideology. It's partisan politics. So if we can't seem to come to terms around many things, but with healthcare, if you go back even into the 1930s, in the 40s they hired the American Medical Association hired Ronald Reagan to do ads against socialized medicine. And there's been enormous opposition to changing the revenue streams. And individuals and organizations work very hard to keep their revenue streams stable and predictable. Special interests, the lobbyists, the pharmaceutical houses, everybody else. And indifference, I think we have a more indifference about this issue than people will acknowledge. I think that's what tripped up the Clintons, beside the fact that the thing was technologically complicated. They banked on the fact that they had all those TV ads, those of you that remember, about this poor person who didn't have insurance, and don't we care about them? And of course you do, because that's nice to say, I don't care about that person who doesn't have health insurance. But when push came to shove and it came down to votes and producing resources to do something, the support wasn't there, and they banked on too many more soft or ideological things. So it's been very hard to get healthcare reform pulled off. This is the public's view of healthcare reform. The blue is favorable, the orange is unfavorable. So there's absolutely nothing there that says that the United States is overwhelmingly in favor or opposed to the Affordable Care Act, because the lines have crossed back and forth over time. And the line at the bottom is don't know or refuse to answer. And this runs through April of 2015, so this is very current polling data on what the country thinks about the Affordable Care Act. But when we get it sliced by political party, we see a little bit of a different picture. So this is everybody. These are the Democrats, very favorable. These are the Republicans, very unfavorable. So you ask how we can get something done. I don't know, with this kind of sheep-like behavior, how we get something done. So, and the independents are somewhere in between, which is exactly what you would expect. So it really, the perspective on the Affordable Care Act is driven very much by party lines. Also differences in terms of what people think the next steps ought to be. The Democrats are saying on the dark line, the blue line to the left, expand what the law does, move it forward, and the Republicans are saying 58% repeal the law. So until we can get some sort of thoughtful debate on the issues, as opposed to blocks of people voting from a political point of view, it's going to be very difficult to chart any sort of coherent future. When you ask people on both sides of the aisle whether they like certain provisions, there's a lot more consistency. Yes?
Well, isn't it true, as I remember, there was wide-scale polling that indicated, I thought it was like 60% or so, people wanted a single-payer option in reform, and Congress just ignored it.
Because the political special interests, the insurance companies and the physicians, I mean, that strikes horror in the hearts of physicians, because it takes away their bargaining power. Right now we've got the supply side has enormous bargaining power relative to the buyers. Yes.
Sorry, I can't see from here. Is that 2010 or 2015?
This is April 14th, 2015. So this is very current. Yes.
Is the pharmaceutical influence on doctors out of whack right now, or do you think they're not?
It's much less than it used to be, much less. Many practices have banned the detail men from coming in. They don't let them bring pizzas anymore. I remember when we used to be offered trips to the Caribbean, for free, if my wife would go to one session and then come back and give one class on a drug, because she's an academic physician. We never did any of that. But those things are just not offered anymore.
You don't see that as
No, not as much at all. Yes.
You say that political parties typify this, but isn't that the same as saying economics? Because Democrats are as a whole in a lower economic status than the Republicans. So it's a matter of those that got and those that don't.
There's certainly part of that. I mean, we have to go back and pick apart the demography of these groups, who they represent. But I can't believe that Democrats, if you talk to people who identified as Democrats, as much as Republicans, there would be this much of a difference. This is driving political process. Yeah.
Is there any study that indicates which of those components of people have an accurate picture of what the law actually
Oh.
provides?
Depressing.
Because
When you
that's-
ask people,
that-
do you know what
so
it
much
is?
misinformation,
They don't know.
disinformation, that it makes any sort of rational discussion
Right.
almost impossible.
Right, and these people are very poorly informed. Very.
Tom, is your sense that if, say, in 2016, we have a Republican president elected, it seems to me as if the provisions, when you break them down, people like what's in there.
Right.
I can't believe that if we elect a Republican, they're gonna just get rid of the whole
Really?
thing.
They can't. I think it would be very hard because there's so many provisions that people really like. And you get all the way down to the individual mandate. And then people say, oh, I don't like that one. Well, you cannot have pre-existing condition exclusions and guaranteed issue and no individual mandate, no mandate to cover insurance, because people will simply, the notion of adverse selection, as the economists use it, will trigger, and that means that healthier people will stay out of the pool, sicker people will join, the cost will go way up, and the insurance companies will implode, and the economics will implode, and people will buy insurance the day before they think they need something done. So we have to have everybody in the pool in order to have rules that don't compromise people who may have a pre-existing condition or some other issue, or the rates get completely out of whack and nobody can afford it.
It's
So-
not too dissimilar to auto insurance.
Yes, yeah, it is.
Has anybody done any research to find out how many people actually don't like the health plan, or they are just so against Obama that they won't vote for it?
Well, I think that it's teased out when you ask these same people who are vehemently opposed to it what to explain it, they don't know what it is. That's the problem.
Rather than a whole reform, has anybody ever considered looking at the waste?
Oh, yeah.
Is why we spend so much?
It's a part of it, and I've got a whole 2-hour lecture on dissecting the costs and identifying piece by piece by piece where we think the excess spending associated with wealth is, and they're piece by piece by piece by piece. The regulators have tried over the years to address those pieces, but have been unsuccessful. So let me keep going, and I'll kind of come back to that. So health insurance reform is not health system reform. That's one of the most important things to remember about the Affordable Care Act. It did not set out to reform the healthcare system. It set out to reform the insurance system and address problems in the insurance industry, not in the fundamental delivery of care. And it's a private sector solution, very much a private sector solution. We ruled out public option. We ruled out people who, the rank and file might have liked it better, but the special interests did not. But it's really the cost of care that sparked the discussion, and that's what needs to be attended to. But the Affordable Care Act improved access. It did not fundamentally address the costs associated with the healthcare system. So this is just a quick summary of some of the elements of the Affordable Care Act. We expanded Medicaid. Didn't affect us here in New York because we already had expanded Medicaid past the point of the expansion that was triggered in other states, although I'll come back to that in a moment. Insurance exchanges with standard policies and subsidies. So we actually created a system where you can compare policy against policy against policy, which is very hard, has been very hard to do and virtually impossible before. And there are subsidies for people at lower incomes to purchase insurance that go hand in hand with the individual mandate that you have to purchase health insurance or you're fined or taxed, depending on what interpretation you make of the law. In the Netherlands, if you live there and you don't buy health insurance, when you file your income tax return, you have a form to fill out, much like ours, that tells them what insurance you purchased. And if you didn't purchase insurance, you get a bill for 100% of the cost of the insurance. Because everybody's supposed to have it. We told you you're supposed to have it. You don't have it, you have to pay for it. There's subsidies for people in lower income groups. And there's no dental coverage in the Netherlands. Certain insurance loopholes were eliminated, pre-existing condition clauses, rescission. Anybody know what rescission is? Rescission is a practice that some insurance companies engaged in where you buy your insurance and have a claim, and then they would go through the policy and find out you didn't put your ZIP +4 in. How many of you know your ZIP +4? Yeah, you're lucky. So if you didn't have your ZIP +4 in there, they would cancel the policy and deny the claim because you obtained insurance fraudulently by misrepresenting who you are. And rescission, insurance is regulated state by state, which is an interesting notion when you think about the big debate about people saying, well, I want to buy insurance across state lines. Why can't I buy insurance that's issued in Mississippi? Well, you can buy it, but it doesn't cover OB, it doesn't no maternity coverage, it doesn't cover this, it doesn't cover that. So different states regulate insurance differently. In New York State, we've been protected from some of these practices because our insurance regulation is very intense compared to Mississippi or Texas or some of the other states. Insurance coverage for kids up to 26 years on parents' policies. How many of you had that be a positive variable in your own lives and your own families? You know, it's huge for a lot of people. Last thing you want to do to a 22-year-old who's graduated from college, hasn't found a job, is to burden them with $10,000 or $15,000 worth of debt because they got appendicitis. Some of the delivery system reforms, and there are a few payment demonstrations. We'll come to that in a moment. Very important part of the Affordable Care Act, very important part of the current portfolio of policymakers to reform the way healthcare is paid for so that the delivery system readjusts itself as opposed to the regulators trying to adjust the delivery system. I teach a course in Medicare and Social Security reform with a guy who's one of the public trustees of the Social Security system. There are 4 cabinet officials and 4 presidential appointees who run the Social Security system. And John is one of them, and he's encyclopedic in his knowledge. He's scary. Students are scared of him. And he was the Undersecretary for Policy at the Department of Health, Education, and Welfare years ago when I was this hospital CEO. And I remember the things that they came out with that try to reduce spending and change the delivery system and affect how we provided care. And I would just laugh at it and say, yeah, I remember that. We figured out how to get around that by doing this. Yeah, then you came out with this policy and we figured out how to get around that by doing this. So the delivery system is faster than the regulators. So we figured out every time the regulators came up with something to reduce spending or change our behavior, we figured out a way around it and beat them at their game, which is why the regulators have reached a point where they're now putting the burden in the delivery system to create their own change, and we'll talk about that. Clinical effectiveness review, funding to determine whether or not some of these expensive technologies that we use actually make a difference. Robotic surgery, biggest boondoggle ever. A robot costs $1 million to install, and then a couple $100,000 a year just to maintain. It is very effective for certain procedures. It's more expensive and has longer surgical times for other procedures, and the outcomes are exactly the same. But surgeons like toys. They like to play with things, and there's multiple hospitals, and if you don't give me my toy, I'm going to go next door, they're going to give me my toy. So, which is why everybody has all these robots, and the advertising associated with it is great. If you drive down 690 from downtown to DeWitt, by the time you get to DeWitt, you want to have surgery or something because it all looks so good, It's like, why can't my wife and I were traveling. Sometimes we got off a plane and there was this big billboard for this medication, and there were happy people, and it was this pill, and so I said to Pamela, get me some of those. And she said, I don't know what they're for. I said, it doesn't matter. They look really happy. We should get them.
Well, it seems like Leonardo da Vinci is actually doing a procedure, since they named it after
the Da Vinci robot. It cost $1 million. We have many of them here in Syracuse. I've been asked by the hospital administrators to stop this conversation. I should not be telling you this. That's the way it goes. Primary care emphasis in medical homes. We have a push. Now, finally, I have an audience who remembers Marcus Welby. Right? That's medical homes. With Consuelo, she was there 24/7. I don't know what that relationship was. And no matter what you needed, Marcus Welby was there, he would come to your house, he would do brain surgery in the office, everything was fine. And he knew who you were, and he knew who your parents were, and he knew your grandchildren. So that's the medical home. It's actually a place where they know you and can coordinate everything that you need. And we're seeing medical homes and the primary care emphasis happen here in Syracuse. St. Joseph's has a couple medical homes established, one on the near west side, one on their own campus. We have some efforts toward wellness and prevention. There's money for wellness and prevention, not enough. The Congress began to refer to the $1 billion that was set aside to do prevention and wellness as Obama's slush fund. And they rated it to pay for the expansion of unemployment insurance after the recession. So we've lost that opportunity to make those investments in wellness and prevention. Quality initiatives, we can always add, do more to improve quality. There are certain quality issues. And investments in information technology. We are among the least invested in IT of any developed country in healthcare. Move to Taiwan is the best. There's a card. And that card has all the payment stuff on it, all your medical record on it, everything on it. You go in to see the doctor, boop, they put the card in the computer, your medical record comes up, they do whatever they need to do, they enter the information, it bills the encounter, you pull the card out, give it back to the patient, on you go.
Friends still, I understand.
They have more IT investment than.
Well, the advantage there is that you can go from doctor to doctor to doctor to hospital without, Upstate runs their own little MyChart operation. Having St. Joe's get that information is a little bit of a conquest. It's a deal. But that card thing, I have a friend who thought about this card thing 15 years ago, to transport the information all on a card.
But
Didn't have the funding to make it.
Well, every hospital IT system, not every, but many, they're different. They have different interfaces. And then we have this horror of confidentiality and privacy in the United States. It's second to none, which is, I don't minimize it totally, but we get in our own way with that. So how many of you have gone to the doctor and after having had a blood test or an x-ray or something, you're sitting there and you want to know the results, right? Because you went through, got stabbed and paid through money. And you say to the doctor, what are the results? I don't have them. And then they chase around, you have to come back next week. Or somebody, the nurse will call you. And then you're sitting by the phone and the nurse doesn't call you. And when you talk about waste, part of the waste is not intentional waste, it's the systems create the waste. But it requires investment to get around that in IT, for example. So there's a lot of stuff inside the Affordable Care Act that are moving parts. We've had a whole bunch of lawsuits. The first set of lawsuits said that the law was unconstitutional. It was upheld. It was determined to be constitutional. The piece that was an interesting part of that lawsuit that the justices sustained was that it said, no, states, you don't have to expand your Medicaid programs if you don't want to. You can keep the Medicaid program you had in place before. The original Obamacare law said you have to expand, every state will expand Medicaid up to this level, the federal government will pay the majority of it, but Medicaid eligibility will go up to this level, and then subsidies will kick in at this level and go forward. So some states, Texas, Louisiana, Mississippi, the southern states notably, said, no, we're happy with the way it is, we don't want to increase Medicaid eligibility. They sued, they were part of the suit, they won, and the Fed said, no, you don't have to do that, which is an huge precedent-setting move on the part of the court, because that's the first time the court's ever said to the federal government, there are limits on what you can force the states to do by withholding or giving money. And I say force, but incent. So for example, when the feds decided that the speed limit should be 55, they simply said to the states, we're going to tag 55-mile-an-hour speed limits to access to federal funding for roads and bridges. So either you can reduce your speed limit down to 55, or you don't have any federal funding for roads and bridges. So everybody did it. With this case law in place, the federal government could be challenged and could lose this kind of argument, because now the feds are told, no, you can't force the states, you can't withhold the Medicaid money and set criteria that the states have to meet. They can keep the Medicaid programs that they had in place before. So what did that turn into? here are the states that decided to expand Medicaid and who did not. All the blue states did not expand Medicaid. 21 states did not expand Medicaid up to 133.5 at the federal poverty level. The orange states either did or had already done so. New York had already done so.
And look where the blue state.
Yeah. And I can give you a list of states you do not want to be poor in, because it's, systems are much less generous. So that's what the state decided to do. So what happened was, interestingly, the subsidies for people who want to purchase insurance on the exchanges who are lower income in the law were written into the law to begin to cover people here. And the states, so this is Medicaid. So the states who chose not to expand their Medicaid coverage up to here essentially precluded these people from being able to access a subsidy. So they're ineligible for Medicaid. Their incomes are so low that it is difficult for them to purchase full rate health insurance. So, and they're not even eligible for a subsidy at all, because the numbers in the law assumed every state, of course, would expand Medicaid. Didn't contemplate that states wouldn't do that. So this is a huge problem in a number of states, and we don't really know where that's ultimately going to turn out. So now we have another lawsuit in place, King versus Burwell, which is under right now under review by the Supreme Court, that said no, the Affordable Care Act never contemplated states that did not establish their own exchange. Because again, the law just assumed every state would do this. Well, some states did not. So the states that did not establish their own exchange, the lawsuit basically says, well, the law says that people who get their insurance through an exchange operated by the state are eligible for subsidies. But if if that exchange is not operated by the state, then there is no subsidy available. So there's another whole group of people now, depending on what happens with this lawsuit, that may not have their subsidies available to them because they got health insurance through an exchange operated by the federal government as opposed to the state government. And that's a map of the states where this is, in this lighter blue line, are federally facilitated marketplaces. So these people in these states, very same states, who got insurance through the exchange will not be eligible for a subsidy if the case is sustained.